Welcome to the Philips Virtual HIMSS Learning Zone. I'm delighted to introduce our presentation, The Future of Population Health. And please join me in providing a warm welcome to our speakers. Cynthia Berghard is a research director with IDC Health Insights, where she is responsible for the value-based healthcare practice. Areas of research include analytics, population health workflow, and proactive patient engagement. Cindy Gaines is the clinical leader for population health management at Philips. She has over 28 years of healthcare experience, splitting this time between quality and operations across the continuum of care. At this time, I'll turn it over to Cynthia.
Thank you so much, and welcome to everyone. We talked about doing a presentation and have actually done a fair amount of research over the last couple of months about what's the next generation of population health look like. We've gotten pretty good as an industry to close gaps in care and start meeting those quality guidelines, but I think it's becoming clear that we need to move beyond managing short-term chronic care, that between the aging of our population worldwide and the lack of caretakers moving forward, we need to develop strategies that will help us manage an aging population that has multiple chronic illnesses and that frankly wants to be taken care of at home and not institutionalized. So we first built a model that talks about this acuity continuum. So why don't we start talking about that acuity continuum, and then we'll move along to begin to talk about how do we evaluate and what is the maturity of the industry in terms of its ability to meet the model or framework for the continuum of acuity. So let's get started with the first slide. So what we did was to take a look at very broad categories of acuities. So along the bottom, we'll see, starting in the left, preventive care, taking a look at the stable chronic care, the rising risk, the transitions of care, and then ultimately the unstable and the frail. And clearly those are very broad categories, and there's going to be variation within each of those categories. But for the purposes of building the framework, we settled on those four categories of acuity, if you will. And then we took a look at what are the strategies, what are the technologies that we need to put in place to go all the way from preventive care up to managing unstable and frail individuals in their home. So the first bar that you see is around analytics. Clearly, you need data across all of the areas of acuity. It's different kinds of data, it's different kinds of analytics. So for preventive care, pretty simple descriptive analytics like, how many steps did you take today? Did you get your flu shot? Did you have your mammogram or whatever those preventive screenings are? So very simple descriptive analytics. Pretty much the same with stable chronic care. As long as someone's stable, we don't really need to start introducing things like predictive analytics, although being able to identify individuals who are pre-diabetic or are likely to get COPD will certainly help us manage those cases. And then ultimately, we want to get to more prescriptive and predictive analytics. So when you start looking at unstable care or transitions of care, the analytics needs to become more sophisticated. And clearly, when you get up to the frail elderly, the dynamics of social care and human services and mental health and clinical care all need to be taken into consideration. So it's all about analytics, but it's about different data and different strategies. The same with wearables and mobile applications. A Fitbit can be used in a very simple way to count steps, to make sure that you're moving around during the course of the day, or it can be used to take a look predictively on the possibility of atrial fibrillation. So are there indicators of something more serious? So as you move across to that continuum of acuity, while it may still be a mobile device or it may still be a wearable, it may be, the data may be in fact attached or part of an alerting system. part of an overall care plan. So while the devices are the same across this continuum of acuity, in fact, they're being used very differently. When you start taking a look at rising risk patients, patients who are unstable in their chronic illness, individuals who are in transitions of care, you start taking a look at the clinically approved, if you will, remote monitoring and things like virtual visits. A lot of the technologies in the wearable and mobile applications are consumer grade. They're not medical grade. That's one of the differentiations to keep in mind. So sending a patient home after a heart attack, you may want to monitor their blood pressure, monitor other vital signs that again are part of the overall care management strategy and data that's needed to manage those patients. And then finally, as we mentioned earlier, as the acuity increases, we need to take a look at a broader spectrum of the factors that in fact could affect an individual's health. If someone is at home and has no transportation, if someone is at home and has no support, they're likely to deteriorate more quickly and end up in the emergency room or back in the hospital. Whereas if we can combine technology with the appropriate direct patient care, we can keep those patients stable and keep them in the home. And let's face it, we all would rather be treated at home than in an institution. I was listening to a presentation the other day that was actually an IDC presentation about the future of technology, and they were talking about moving technology, and I mean this much more broad to all industries, sort of out to the edge. So distributing it, whether it's across banking or across finance. And the CIO of ChristianaCare was on a short recording, and he was talking a lot about how healthcare organizations, delivery systems really need to begin to think about placing technology beyond their four walls. So being able to treat patients at home, being able to treat them in nursing homes more acutely. So I think there's a growing recognition, if you will, of the need to manage patients differently outside of the four walls. And so this gives you some sense of what our thinking is about what's that next generation of population health going to really take a look at. It's a much broader view of the use of technology. It's a much broader definition of population health, and really it includes that integration of clinical, social, human, and behavioral health. So let's talk about where the industry is in terms of this model of population health. And we'll move to the next slide and start talking about how we are applying the IDC methodology and framework for maturity of a technology against our vision of population health. So what you see across the top are the 5 stages of maturity. On the left is ad hoc, moving through the experimenter, the practitioner, the expert, and then the guru. I'll talk about each individual stage in high-level terms, and then we'll drill down on a couple of the dimensions that we thought were most important to share with you. Because obviously population health is much broader than just a technology or just a set of nurses. There are multiple dimensions. So let's talk about the dabbler. So this is about an ad hoc, oh, look, there's an at-risk contract. Let's grab that and see if we can manage it. Learn from it, not a lot of risk, small contracts. Moving on to the experimenter, organizations begin to realize that in fact, they can change the trajectory of patients' health. They can intervene and get people to get their preventive screenings and close their gaps in care. But not a lot of organized processes. Really, I'll take whatever data I can find. No one held accountable for the results of those indicators. And then you go to the practitioner, which is where I think many organizations are headed, somewhere between the experimenter and the practitioner. Where at the practitioner stage, more risk is taken on. There are processes that get developed. People have accountability. Investments are made in unique technologies. It's not just, oh, I'll grab this data set because I have it available. It's about designing the data set. It's about having people trained and becoming accountable for the results. The expert, that's when you go from we can do this in a couple of physician offices to really an enterprise approach. So those processes that have been put in place, the data harvesting and analytics capabilities move up to an enterprise level. So obviously much more of a need for communication, for standardizing processes, for holding people's feet to the fire in terms of their accountability for what they have said they're going to deliver. And then the guru is where it's sort of optimized. And I like to think of that stage as becoming part of the fabric of the organization. So it's part of the culture. It isn't, people don't think of, oh, I'm treating Cynthia because she has a strep throat. It's I'm treating Cynthia and she has a strep throat. And oh, by the way, I need to ask her how she's doing with her diet for her pre-diabetes. So really a different mindset of the culture. So now what we're going to do is start talking a little bit about the different dimensions and and the maturity of both clinically integrated networks and integrated delivery systems. Obviously, those are two very large and diverse segments of the industry. Um, and it's pretty obvious from the graph, there are strengths um, for integrated delivery systems that might not be strengths for the clinically integrated networks. And conversely, the clinically integrated networks have some really interesting strengths that are harder to deploy and adopt in an integrated delivery system. And again, this is a framework just to help organizations think about getting to population health in some kind of a stepwise fashion, and to think about it beyond just a technology or just changing the nurses or doctor's way of treating a particular kind of patient. So what I'm going to do is ask Cindy to talk a little bit about the dimension of leadership and of process. She's had feet on the street and she knows this far better than I do. And then I'll take a look at the data and technology issues. So Cindy, if you would talk a little bit about our findings around leadership and process, that would be great. And comparing and contrasting where the delivery systems are versus the clinically integrated network. So take it away.
Absolutely. Absolutely. Thank you so much. And I appreciate your kind words. The thing I love about this model, Cynthia, is the fact that it really helps you strategically to assess where you're at. Because I do think we think of population health, it's population health management can be this buzzword. Of course we do pop health. But really strategically, what's your approach to that? How do you get to where you want to be? And what I love about this is it recognizes that in the different dimensions, you're going to have different strengths. So when you're able to assess yourself really honestly and say, okay, so if I'm a dabbler here, but I might be a practitioner in this other component, and I might be an experimenter here, that's really normal. And it allows you to say, where do I want to put my resources? Where do I want to go? What can we do in the next year? So it gives you just a really great view of what's going on in your organization. When we talk about leadership, I want to just make this real for you about between the dabbler going up to the guru. And when we think of leadership, where population health lives in your organization tells me a lot about the leadership, and they're not right or wrong. It's just how our worlds grow up. And that you can walk into an organization and you say, who does pop health? Our director of case management's in charge of population health. Um, and what you'll often see is that lower down in the organization, that responsibility lies. Typically, the lower down in this maturity scale you're going to see, because it becomes about what you can control in the scope of what you do. So if you have a manager or director who's responsible for it, oftentimes they are focused on a project, going after a contract, improving pay for performance in a particular practice. And then they'll start experimenting. So, oh, let's standardize this across these 3 primary care practices. And when you start to expand the scope of what you can do and the bigger the work you can take on, usually we'll see that leadership's moved up to, oh, it's now the responsibility, the chief medical officer is accountable for pop health. Or, we have a chief quality officer, or we have a vice president whose role is population health, and they sit at the C-suite table. And I know in my past, I've lived all those roles, but my last role was I was responsible for pop health, both as the president of the medical group and as the vice president of population health. And we weren't dabbling anymore. We were doing robust projects. We were implementing system wide because my scope was large enough that I could control that. And that's in many ways why you see the difference between an integrated delivery system and a clinically integrated network. When you become a clinically integrated network, there are truly laws, federal laws of that you have to structure that around and comply with to really become a clinically integrated network. So I'm not surprised that leadership and for a clinically integrated network would score so high. You have to spend a lot of time in setting up a clinically integrated network to make sure that the governance and the infrastructure meet the needs of those federal requirements. Where if I'm an integrated delivery system, which is often what most of our health systems are, it usually starts at a lower level and starts to move up in the organization. So not a big surprise is there'll be a lot more focus on leadership and infrastructure in the beginning, and some of those other processes later on where you'll see that the integrated network will be stronger. Kind of the same with processes. If we think about processes, if your processes become, we're going to, do you allow each provider to determine their process for managing diabetes? Is it standardized across your practice? Is it standardized across your entire primary care group? And do you have measures? Do you hold the providers accountable to that care? Do the goals and the organization align between the staff and the providers and the executives? And then you start to, as you move up that, you go, wow, we have independents in our community we need to coordinate with, and you start to coordinate that diabetes care across your specialists, across independents. Again, you're going to see that will become more standardized. You'll measure to it, you'll hold performance to it, and you'll say, this is our standard of care and this are our expectations. Again, not surprised that a clinically integrated network would score really high on this. They often have requirements and expectations set in the contract. For an independent, if you're going to be part of our clinically integrated network, this is the standard of diabetes care we expect you to perform at. These are the processes up front to be part of that, and they hold you accountable. So they typically score pretty high in the beginning, where again, a medical group that's in a typical hospital level, there that standardization usually starts small and starts to expand. And again, usually that expansion follows the leadership trail and that ability to hold those practices, those providers, and the organization accountable to their processes. So neither is right or wrong. They just have different places they start at. And then you'll see in some of the other processes that Cynthia's going to talk about that the integrated delivery system starts out stronger where we have things to learn from that as well. So Cynthia, I'm going to hand that over to you and see where you can show us about data and technology.
Thanks, Cindy. I found it really interesting that on the technology and data side, the integrated delivery systems were really ahead of the clinically integrated networks. And as you were saying, I think a lot of it has to do with where they started. Most of the major wave of implementing electronic medical records systems occurred in integrated delivery systems well before they did in the clinically integrated networks. So they started at different places. So I think the juxtaposition is really interesting. So if you look at the data piece, even the integrated delivery systems are still struggling with creating a single source of truth integrating their clinical and financial data, struggling with issues of interoperability, but they have been at it longer. So they had EMRs earlier. They had cost pressures to address. They had technology available to them at their scale to help them support the analytics and the data capabilities. Whereas, and they frankly had budget to allocate to the acquisition of data and analytics. So, and they had more sophisticated people, frankly. They had an IT department and they had people who understood the data sources. That's not so much the case in many of the clinically integrated networks that I've seen. They certainly are developing that capability, but they're really at the walk stage, as we can see here. You know, they're experimenting. They're trying to see what it's going to take to integrate their Epic data from one provider group with their Epic data from another provider group. They may be beginning to bring in some of the financial data from the payer, but at a much earlier stage with a much less, typically much less sophisticated staffing. But I think they will catch up eventually once they get those foundations in place. And the same trends really exist around the technology. As I said before, providers have more budget. They have been investing in analytics applications. They have care management workflow applications, either through specialty vendors or through their EHR vendors. And they are beginning to learn how to outreach to patients. And they have technology, albeit many of them still focused on using their patient portal instead of more digital focused outreach. And the clinically integrated networks are just beginning that journey of technology investment. They are much smaller organizations. They're pretty lean and mean from what I've observed in terms of how they're staffed. There isn't a large administrative staff, and there certainly isn't a large IT staff. And quite often in the early stages of the clinically integrated networks, what I see is them using technology that was part of one of their partner hospitals, for example. So I think the interesting juxtaposition here is that in areas where you need a lot of control and a lot of oversight and accountability, the leadership and process are stronger and more advanced for the clinically integrated networks. Because as Cindy was saying, there are very senior level people running those initiatives that have authority and have accountability. And frankly, on the clinically integrated networks, they have to pay the bills at the end of the month. So there's a financial incentive that's pretty strong there as well. Whereas on the delivery system side, the strength is in their previous investments and in their overall capabilities around data and technology. And so in closing, what I'd like to say, and then Cindy, if you want to make some remarks, feel free to, is the whole concept of population health management, although becoming clearer, is still a confused concept. I think organizations put their toes in and they don't know where to go. And so by providing both the kind of framework of how to think about what population health needs to look like down the road, our acuity model, and then looking at the dimensions and the types of maturity and what it takes are really hopefully very useful tools for you as you continue your journey around population health and improving the health of the folks that you're responsible for. So Cindy, I didn't know if you had any closing comments or if you wanted to move into the questioning time.
I think just in closing is that it's just to remember that we're all on a journey with population health and we never arrive. It's kind of constantly moving sand that we're standing on. The fact is we live in a world where my medical group or my hospital may be its own integrated delivery system, and it's part of a clinically integrated network. So we live in these different worlds that evolve and change because all of a sudden you combine with another medical group or another health system. So you may move back and forth in this maturity, and if anything, it's meant to give you a visual so that as you and your team, your leadership team, are making a plan, you can strategically look at where you're at and where do you want to be, and just recognize you don't arrive, and it may shift back and forth, and that's okay. It just helps you to make a plan for where you want to be.
Okay, we do have some time for questions and we can move on to those. I will just pose these for both of you and let you tackle them together. So the first question is, do you have any recommendations on where to get started, one category versus another?
I will jump in on that one. That one's a hard draw. There's two that come really close to me, but I would say I would start with leadership. And I say leadership from the perspective of whether you're an integrated network or you're a delivery system, that ability to standardize and manage performance and create accountability and strategy is so important to moving into that future state, that you really need that strong leadership that is at the decision making table. And again, if it's just how you line that in your organization, move towards that, because it will be hard to achieve what you want to achieve if if leadership is kind of buried at a lower level, at a director level. So leadership's an important one to me, followed really closely by data, because you have to be able to kind of know how you're performing to know how to improve. So, how about you, Cynthia? What do you think?
Yeah, I have very consistent feelings with you, as you do. And one example occurred when I was at a conference a while back, and I was having lunch, and sitting at the table was a woman who was in charge of telehealth for a delivery system. And so we got to chatting, and I asked her how or if there was any collaboration between the folks that were managing, sort of traditional telehealth for a hospital versus population health. And she rolled her eyes at me. She said, "Well, a lot of us have been working together for years, and so informally, we might communicate about a patient and make a suggestion that it looks like, patient A is not taking her blood pressure, and we know that that person is under a pop health program, and do informal communication." But I think it's a real example where the lack of leadership um, really holds an organization back, because clearly telehealth and pop health, should be joined at the hip and should be sharing data and communicating on a regular basis. So I think that was a good example for me of the need for, leadership at the highest level. And, we all know that good decisions require good data. So
Yeah.
that's the next thing to follow. So I think we're really in sync in terms of what we think is important. And even, leadership from a position of, we only want to go so far. Our organization can't sustain a guru position, but we can really sustain um, the expert position, and being able to kind of draw the line about where the organization wants to go, and then lead that organization
Yeah.
there. So
And another good example is just when you look at organizations, so much of the structures are, this is our inpatient structure and this is our outpatient
right.
structure. And if you really think about population health, it's about managing that patient across that continuum and beyond, and managing in their home environment, that transition to home, and which is where they spend the majority of their time. And yet our infrastructures are set up so separate. And what I see again when you look at that maturity is when someone has a leader who crosses that continuum, that really is a sign of maturity, because you're connecting those two worlds as opposed to the fact that they just happen to work side by side and hand off.
Yeah, it's also a reflection of sort of patient centricity versus operational centricity, which I think
Yes.
is really an important one.
And that is an excellent segue into our next question, which is how do the social determinants of health fit into population health management?
I'm happy to take a crack at that. I just published my first report that will be the first of a series of reports on the social determinants. And where I've come down on that is integrating clinical, social, human, and behavioral needs and services for the highest risk patients is where you're going to get a good return and be able to create scalable solutions that are sustainable. Um, Understanding the clinical risk and the social risk of an individual so that programs can be designed and personalized to that individual, covering that full scope, is most applicable in the Medicaid population, for example, where we know by its nature there's going to be income insecurity and likely other social challenges. I saw a data point the other day that I think 25% of people over the age of 65 are living at just about 200% above the poverty level. So there are impoverished seniors that will obviously have social needs. Um, I don't think it's a boil the ocean, like every data needs to be collected on every patient um, about their social determinants and their social vulnerability, because I don't think it's as applicable, and I don't think you'll get as much of a impact um, with someone who occasionally needs a ride to their doctor's office versus someone who is homeless and is food insecure and ends up in the emergency room because they can't manage their diabetes. So that's kind of where I've come down on it. But it absolutely has a role in managing people. And again, kind of at that far right of the acuity continuum that we just discussed earlier in the presentation. And I think a lot of the hoopla, if you will, about social determinants of health is kind of settling into the reality that there are some populations that can really benefit from this, but we have a lot to learn about how to integrate those services, both intellectually and then operationally. Cindy, what's your feeling? I mean, you certainly must have seen patients in your life that would have really benefited from, a different kind of support system.
Oh, absolutely. I think the big aha for me was social determinants of health when we stood up our case management program was how that those social needs really drove the majority of our case management work in the ambulatory setting. And kind of what struck me is it's forcing us as health systems to really embrace our community resources. I think historically, I've been in healthcare so long. Historically, it's if we had a need, we built it. And as health systems, we're really good at building things. And oh, we need that, we build that program. And the fact is, we need to stay focused on clinical and stop trying to build great resources that exist in our community and really partner with them. And it's created a different relationship with our community. Hospitals really are many times the foundations of their communities, but we often have amazing resources in them, such as a food pantry, uh, a shelter where you can get clothing, pharmaceutical assistance. There are so many great community resources that it's about helping our patients to connect into them. And I think the challenge is just as we've tried to figure out how to do referral management with our specialist, and I make a referral, you get your need met, and it comes back. So I know if your need was met. It's setting up that same process with our community resources of I'm going to tap into that resource, connect you, help you meet your need. Did your need get met back? We don't have good technology to connect to that yet. And I think that's the next big part of pop health is managing kind of that social referral part of it, but not trying to rebuild it in our health systems because we just don't have those resources today, but taking advantage of our community resources and really honoring that great work they do to meet our patients' needs. And we used to just kind of believe we could do it all. And I think we need to partner, but we need to figure out how to connect it so we know what's going on with our patients and can follow up.
Yeah, I would agree there. I think it goes back to the leadership issue. So that's leadership of the health institution as well as leadership within the community in terms of bringing people together around a common issue. I think that's all the questions that we have. And so I just want to say thank you for participating and thank you. That's all I have to say. Thanks, Cindy.
It's been truly a pleasure, Cynthia, as always.
Great.
Yeah, thank you both, Cynthia and Cindy, for sharing your insight today. And to see more Philips Virtual HIMSS Learning Zone sessions, please visit the Philips HIMSS 2020 homepage. Thanks.